Well, hello, hello. I feel like Dr. Singleton is 6 feet away because we're social distancing. Welcome to Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center, and you all know October is Breast Care Month, and Dr. Singleton is one of the radiology folks over there, and he reads the mammograms. So we've been talking about that, and we're going to talk about that in depth tonight. There's so much breast cancer, and this is the time to be aware, but we just really need to, all of you out there need to be aware, and you need to know about self-breast exams and those kind of things. So we're going to start out by welcoming. Thank you, Dr. Singleton, for coming. It's so nice of you to be here.
You're welcome.
And I know
pleasure.
I know that you don't live in town, so it's an effort for you. And
I live 35 minutes outside of town. It's not that far of a drive. But
oh, okay. I live out in the country with the goats. So, when did you decide you wanted to go into medicine?
When I was a young child in Huntington, West Virginia, I was a paper boy, and I delivered papers to a lot of physicians. So my mom's a college professor at Marshall. No one in my family was a physician before, so it wasn't something that I thought was I wanted to do. Played baseball and was in ROTC in college, and I wanted to be a Navy fighter pilot after Top Gun.
Of course.
And but my eyes went. I didn't have perfect vision, and so I couldn't be a pilot in the Navy. And someone said to me in college, who was applying to med school, "Well, you can't go to med school because you didn't. You just didn't take the pre-med classes." And I said, "Well, I was a physics major in college," and I said, "Well, why can't I take the MCAT?" So I took the MCAT and I applied and I got in. And so since the Navy said I could go to med school, I went to med school.
So you were in the Navy when you did that, and then they helped you with your education.
They
That
did.
is awesome.
I spent 11 years active duty in the Navy.
Yeah. I've got the only one I can think of off the top of my head is Tom Robertson. He's the ophthalmologist. He was in the Navy too, and got his education that way. So where did you go to college?
I went to college at Vanderbilt University in Nashville.
Yep, I've heard of that. It's an okay place.
Yeah. I enjoyed it. It's one of the...
Got your undergrad there?
Got my undergrad there, graduated there in 1995, and then went to Marshall in Huntington, West Virginia for medical school.
Oh, followed Mama.
Well, it was in state, and Mom told me that if I went to Marshall, then she would cook meals for me and do my laundry.
Oh, well, that's important.
That was a good recruiting tag right there when you're a medical student.
There you go.
And from there, I went on, did my internship in San Antonio. Was a flight surgeon for 2 years at New River here in North Carolina, and did my residency at Bethesda Naval Hospital in D.C.
So what made you come to this area and not go back to West Virginia?
I was stationed at Camp Lejeune from 2006 2010, and my ex-wife was working in Greenville, and so when I got out of the military in 2010, we moved to Greenville.
Okay. Well, we are blessed to have you.
Thank you.
Think you've been here, I think you said 3 years now?
3.5 years.
So what made you... First you went into medical school, then what made you deviate to radiology versus ophthalmology?
Well, in medical school, you don't get a lot of exposure to radiology. I started off when I was a general surgery intern at a level 1 trauma center in San Antonio, and we would take 100 trauma patients every day.
You were busy.
And you were in the radiology suite all the time, and it was, and so you're in the CT scanner with the patients, and you're tracking down imaging results, and so you're constantly, as the intern, this is back when you didn't have cell phones and iPads and immediate electronic updates. So they called it scut work. So the interns were doing all the scut work, and that meant that we were in radiology, tracking down reports, taking patients down, make sure. And so being in the CT scanner, I was enamored, one, with the technology, and two, that the guy on the other side, or the guy or the girl on the other side of the glass would point at the screen and tell us what's wrong, and then they seem to go off and go do something else. And here I am working 120 hours a week, 50-hour, sometimes, in a row, felt like. But literally overnights, 24 to 30 hours straight, and saying, I want to be on that side of the glass. And that's how, so I went to the radiology program chair and said, I want to switch to radiology.
Was that a problem? Was that a hard thing to do?
For the Navy, it was, because I was tracked towards general surgery. So I was sent out to be a flight surgeon for 2 years. And to move from San Antonio to North Carolina to go to be at New River. And then 2 years later, I went back to residency at Bethesda Naval Hospital.
Okay, huh. Well, I know you saw plenty in a level 1 trauma center.
And then when I was at Bethesda, 2006, 2010, we had, or 2002 to 2006, and then Camp Lejeune, 2006 to 2010, saw a lot of war casualties during that time as well.
Yeah. But your heart is now in mammography, huh?
I do mammography about 30 to 40% of the time. The rest is doing general radiology and ER work and...
Okay, yeah.
And we have one of the busiest ERs in the state.
Yes.
Yeah.
I worked in the old ER. I have not worked in this new one that they have, but I was in the ER for 13 years.
Oh, wow.
Yeah. So
that's tough.
Yeah, the average life of an ER nurse is 5 years. And I was 13. I'm a glutton for punishment, I guess.
My heart goes out to the shift work and
I know.
Being on the front lines, especially now with COVID. It's tough.
Yes. But, the training I got in the ER, just from watching and observing and doing, and, it really helped me to become a nurse practitioner, because I precept students and they'll say, what's a GI cocktail? Oh, Lordy.
Yeah.
And I knew all that, so it's kind of nice. But anyway, enough about me. So, is it hard to read mammograms? I mean, how long did it really take you once you were in school? I mean, you focused on reading x-rays and mammograms?
Well, radiology residency is 4 years after you do the internship, your first year out of med school. And so it's 4 years of radiology in which you rotate through neuroradiology, pediatric radiology, orthopedic radiology, women's imaging, obstetrics. And so you rotate through different areas of imaging, and your proficiency increases as each year goes by. By the end of your 4th year, you become board certified, and you kind of, at that point, you can go do a fellowship or track into an area in which you have clinical expertise, or where you enjoy doing the procedures, or where you find that you're good at something. And for me, I found that I was good at, of course, dealing with the trauma and the general surgery, because I had that background. But the mammography was something I enjoyed, and I realized or learned that I was good at it. And so we tend to track towards things that we're good at.
Of course.
And so as I finished my residency in 2006, and so in the military, I was the lead mammographer at Camp Lejeune, and then when I was at Cherry Point for my final 6 months. And so I just constantly got better at it and got more and more skill sets and the resume built, and so I kind of became a mammographer specialist by that. So I worked for the Mayo Clinic in Jacksonville, Florida, one of their regional hospitals, and was the mammography director for the small hospital there, and then from there I came to here.
So did you like being director? Is that more pushing papers and talking to people?
In mammography, it's not, well, you do things like this. But mammography is more MQSA, the Mammography Quality Standards Act that you have to follow to maintain your certifications, ensuring that the quality of the work is done appropriately, that the techs are meeting imaging requirement guidelines. Mammography, breast imaging is very heavily regulated by the FDA.
I know.
And so meeting those standards, such as callback rates and reporting specific verbiage in your reports, your positive predictive value of biopsies, all those numbers get tracked in big data, and every year they get turned over to be analyzed to make sure you are within the guidelines. And so what they don't want you to do is if your callback rate is too low, if it's below 6%, 5%, the concern is you're not looking at the mammograms detailed enough, and you're letting cancers go by. If your callback rate's above 12, 13%, then you're calling back too much, which means these unnecessary procedures is what the concern is. And so they want you to be somewhere between 6 and 12. 6 to 14% is where the national standard is. And so, following that, and you can follow the trends. You can tell when someone's had a bad or a stressful 2 months when you start looking at their numbers and the callback rates, and you can see them go like this, or you can, but you also get to see the consistency in the way in which the work is being done and performed, and the quality of, and so managing that is part of it. Basically, it's signing a lot of forms and ensuring that we're doing things the right way.
Right. Well, I don't like a lot of the governmental interference, but in some cases, it's very important, and I think this is one of them.
It comes down to the words that we put in our report.
Does it?
Yeah, if it's not said a certain way, then it gets flagged when the FDA comes by. And it's like, really?
Do you think the breast cancer rates are going down, or are they staying?
They're staying pretty steady. It's 1 in 8 women get breast cancer, lifetime risk on average, and it's been that way since I was in residency in 2002.
Yeah,
and so I haven't seen an increase or a decrease. They do have regional areas that they'll talk about across the country where there'll be a cluster that'll pop up, and then that's where the epidemiologists come in and say, why is this little area having an increased number of cancers that came up, and whatever cancer it is, whether it be breast or colon or but as far as breast cancer, it's pretty consistent. It's like prostate cancer. 1 in 9 men get prostate cancer. It affects men over the age of 60 greater, and women, 1 in 8 women. But the issue that's disheartening about breast cancer is what you tend to see is the younger you get breast cancer, the more aggressive it tends to what we see. And so but then it's so infrequent in women under the age of 40. And so there's that debate of when to start.
Well, I was just going to ask that. What is your opinion? And opinions are like noses. We all got one.
I follow what the American College of Radiology.
Okay, what do they say?
And women should start getting breast cancer at the age of 40 annually.
Breast mammograms.
I misspoke.
40.
Get a mammogram at the age of 40.
Okay.
Annually, every year. And for me, the way I explain it to patients is it's because there's other organizations say every other year and starting at 45.
And some say at 50.
Right, and I think that's more along the lines of trying to save costs from the big picture, from government agencies and insurance companies that say, hey, a mammogram every year is expensive. And when the Affordable Care Act became law in 2014, screening mammograms were 100% covered with no out of pay, so it did not account into the deductible. So, but then within 6 months of that, then all of a sudden the recommendations came out to say, we need to do them every other year, because wait a minute, we're going to be doing all these mammograms for everyone. Well, I explain it to women in one simple way. It takes 18 months on average for breast cancer to go from a stage 0 to a stage 2 cancer.
Oh.
Just 18 months.
That's not very long.
A stage 0 cancer has a 5-year survival rate of almost 100%. A stage 2 cancer, and stage 2 just means it's over 2.5 centimeters, and you got regional lymph node involvement. The 5-year survival rate is 80 to 84%. So in 18 months, you can go from 10 out of 10 women beat it to, in 18 months on average, 2 out of 10 don't. So, and I'll say we wear a seatbelt for a reason. And so the screen mammography, if done every year, then we have just increased the chances that woman who 1 in 8 that gets unlucky enough to get breast cancer, we've increased their 5-year survival. And it's that simple.
And if it's you or your mom or your sister, you want that.
Right, exactly.
So
you want the best chances that you can have to beat it.
I had an argument with one of she's a brand new PA, she's fresh out of school, and she said, well, the guidelines now say start at age 50. I'm having all my patients start at age 50, and she's 27 or something.
Right, well, there's also one other, if there's another caveat to that about when to start. So you look and you say primary relative, whether it be a mom or a sister, if they had breast cancer, at what age did that breast cancer get diagnosed? And start screening mammography 10 years prior to that.
Oh, it's 10 years
10
prior?
years prior. So if the mom got breast cancer at age 46, then you start at 36. And then
I didn't know that.
And you can also do a breast cancer risk assessment. A Gale model is the one that we use. And if someone has breast cancer risk of over 16%, then you can start genetic counseling. That's what we recommend. And if they're under the age of 40, then you can go that route to counseling, where they do a genetic counseling session and calculate their risk. And if it's over 20%, then we recommend annual breast MRI. MRI for the breast cancer, lifetime breast cancer risk is over 20%. Wow. So if someone's under the age of 40, and that's the way, and you can say that looks at ovarian, other cancers that are related genetically to breast cancer, and pancreatic, and so that we can assess the true risk, and then maybe they need to start screening earlier. And so the goal is to get women into screening, appropriately screened for breast cancer who need it.
I didn't realize that pancreatic cancer was related to, or could be related to.
Pancreatic and ovarian do have a genetic.
Ovarian, especially estrogen-feeding cancers.
Right. So, all that gets calculated into an equation that the model we use, called the Gale model, calculates a lifetime breast cancer risk. And I include that in my report on a screening mammogram because I have that number. I put that in my report so when you see it, you can say, I said it's 13.4%. But that gives you the ability to look at that when you sit down with your patient and say, hey, if 1 in 8 women get breast cancer, that's 12.5%. Right? That's just the average risk, lifetime risk. You're at 13%, you're barely above average risk, but if I say, hey, your lifetime breast cancer risk is 32%, it gives you that tool in the bag when you counsel and you sit down with the patient to say, this is why we're doing what we're doing. Right. But if you say it's 6%, then you can say, hey, when women are scared, and they are, and you can say, we can't be 100% and say you're never going to get. It's like what's dealing with COVID right now. You can't say we don't know who's going to get it.
That's right.
But we can say that your risk is half of what the national average is. So keep doing what you're doing. Right.
That's the whole thing. So self-breast exams, yearly mammograms. What's the big difference between a 3D and, like, we do screening mammograms at our office? So, and I think, are you doing any mammograms there, or is it all 3D now?
All our screening mammograms are 3D.
And that's what I thought.
And we have Hologic equipment, the same equipment that I had at the Mayo Clinic in Florida. And so it's outstanding equipment that this hospital has invested in. It's one of the reasons why I took the job here when I interviewed here. Looking at the equipment was something I was very familiar with, but it was also the quality of the equipment, in my opinion, is the best.
Wow. And something to be said for little old Rocky Mount, isn't it?
I was impressed when I went 3.5 years ago. And so the 3D mammography is basically, it's a tomogram. And getting technical, what that is basically one image in a slice through the breast. And so if you take the stack of cards and you can flip them, and it'll be the mouse running or playing. So what that enables to do is when we stack the images all together, we're able to scroll through the breast from top to bottom and right to left, and from there what that does is allows us, when you do a 2D mammogram, it compresses the breast and everything is two-dimensional, and you're seeing if a dense breast tissue, you're seeing overlapped other dense breasts. And so what that does is makes the normal parenchymal lines of the breast sometimes look to be more dense or thickened, and it makes some things look like a mass when it's not a mass, because the breast is full of lobules and parenchymal and ducts. And so if they get compressed in a certain way, it can make it look mass-like. So 3D mammography reduces the callback rates for masses by up to, some reports, up to 26%.
Wow,
because
that's a lot.
That's a lot, and that saves money, and that saves time and relieves anxiety. And so, in my opinion, all mammograms should be done in a 3D manner, whether it's GE or Hologic or whoever system's out there. I personally believe the Hologic system's the best that's out there.
Yeah.
And so, because if it's not done 3D wise, then I think the quality just is that much of a difference, and especially in dense breasts. And an analogy I could say to you, there's two analogies. One, when you go to bed at night and you wake up in the morning, your hair's never laying the same way twice, right? And or if you're trying to look through tinted glass or screen, and the more thinner, the thicker the screen, the less you can see through it.
Right.
And so having that extra advantage of doing a 3D mammogram versus a 2D mammogram, it just helps us detect cancer sooner.
Yeah. Wow. All right, I'm going to be in trouble with Lee. He gave me the finger a few minutes ago. So we're going to take our first break, and we'll be right back with more of Here's to Your Good Health. Hang on and don't go away.
At Downey's Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Downey's Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Downey's Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Hello, welcome back. Dr. Singleton is quite a conversationalist. We've been yapping the whole way through our commercial. I like it. I like talking and chatting and doing. So we've had a great first part to this show. If you're just tuning on now, you be sure that you look it up, because you're going to learn a lot about breast care, breast cancer, and our fine, top-notch breast care center with all the best. I mean, Dr. Singleton just said that we have the same 3D machines there that they have at the Mayo Clinic in Jacksonville, Florida. And you know, the Mayo Clinic is a top dog as far as clinics. Cleveland, Mayo, those kind of things. So, all right, so we were talking about 3D, and you talked about dense breasts and fibrocystic. Well, I want to talk about fibrocystic. So what is a dense breast?
We categorize breast density in one of 4 quadrants. Basically, 0 to 25% are classified as fatty replaced breasts with less breast dense parenchyma. Then 25 to 50%, 50 to 75%, and 75 to 100%. So we're by the MQSA, we're required to categorize the breasts in one of 4 densities, and that comes about from, it used to just be required to say. Now, back in about 10 years ago, there was a lot of interest in, do women with dense breasts have a greater increase, or the increased risk for breast cancer? That is debatable back and forth depending upon the literature and your point of view. My point of view on it is 1 in 8 women get breast cancer. It doesn't matter if it's dense breasts or fatty breasts. We see them, we find the cancers earlier in the less dense breast because, like we were talking about, with the difference of being able to see the 3D.
Right, sure.
And so the cancers stand out in a more fatty breast than it does in a dense breast. And as women get older, their breasts tend to become more fatty replaced and less dense. But I've seen 40-year-old women with completely fatty replaced breasts, and I've seen 75-year-old women whose breasts are still extremely dense. And so what happens with women with more dense breasts is that they typically, in my experience, we will detect the cancer at a later stage than we would on a less dense breast, on a more fatty breast, simply because we can see it better. Now, the 3D helps us a lot, and the risk counseling and the risk screening assessment, and then MRI allows us to try to detect the cancer sooner. But the reason 12 to 20% of cancers are still diagnosed by the self-breast exam, where a woman says, I feel something, and then they come in and we find, and then we do a mammogram or a sonogram, and we see a breast cancer. Now, those typically happen in women, unfortunately, it happens more often than not in the women that don't get an annual mammogram. Because as that 18-month rule I talked about earlier, it has the growth of the cancer has to have time to grow to a point where you can feel it.
Right.
And so when women come in and say, oh, I feel something, and this is a teaching point for you, is if a woman has an annual mammogram every year and she feels something, and the mammograms have been negative or benign findings, the likelihood of what she's feeling to be a cancer is lower than it is with a woman who hasn't had a mammogram in 3 years.
Right.
Because of that time factor. It doesn't mean it's not a cancer, it just means the likelihood is lower.
Right.
And that's something that I tell women when we reassure them, because a lot of times what they feel is just is normal lobulation within the breast. It could be a cyst. So when I give public talks, I say, don't panic. We see a lot of women come in and I felt this last week.
Right.
And they're in now, and we don't see anything, or it's a cyst. And so when I give talks out in the public, we'll go out, before COVID, go out about every 2 months and go give a talk somewhere.
Everything's BC.
Yeah, BC, exactly.
COVID, yes.
I say, if you feel something, do your monthly breast exam and do it on the same day each month. When I was in the military, it was really easy because we got paid on the 1st and the 16th, and you can't do that now.
Right.
And so I say, time it with something, a monetary event that always happens on the same day each month, whether it be a student loan payment, a car payment, a house payment, or you got money coming in on the same day each month. Do your breast exam on that day. When you feel something, don't panic. Do it again 30 days later on that same day. Again on the 60th day, and again on the 90th day. That's 4 data points. If it gets smaller, it's not a cancer. If it stays the same or gets bigger, then come in to see us, because if you run in after seeing it for 7 days or feeling for 7 days, and it could be a cyst, it could just be area of the breast that's responding to normal hormone changes. It could be a hematoma from trauma, and the woman's gonna come in. I feel something right here. We do a diagnostic mammogram and a sonogram, and it's money out of pocket because that goes towards the deductible, and so you're gonna get a bill, and a lot of the times, more than 50% of the time, it's not a cancer. We did, in 2018, 2019, we did just under 9,000 screening mammograms. Between 2019, 2020, in the same time period, we did 8,100. screening mammograms. It was down because of
COVID.
BC. And we were down in March where we were only open 2 days a week.
I know. And I had a lady that had a horrible, I mean, her breast was like a
Yeah.
like a muskmelon or a cantaloupe, and I couldn't get her in.
Yeah, and we didn't have any spots, and we didn't have the time spots in the
Right.
hospital.
I know. I mean, I'm not,
It wasn't the
I'm
hospital's
blaming
fault.
COVID,
Yeah.
but, you know,
And,
she's elusive.
so, I forgot our train of thought, so we...
Oh,
and then-
you were saying the amount of numbers.
And then, we diagnosed primary breast cancers that weren't referred to us. We diagnosed just under 200 cancers. So, the cancer rate is not out there as if cancer's everywhere in the community. Breast cancer, it does happen. But it's not that everything that you feel is not a cancer.
Right,
But
right.
when women come in, a lot of the times, they're scared. And rightfully
Sure.
so, but we can walk in a room and sometimes tell a woman it's a benign cyst, and she's on the floor thinking that she has cancer because she's scared.
Yeah.
And then the converse is true. I can walk in to another lady and say, ma'am, this is abnormal, we need to biopsy it, and, we need to schedule this, and, okay. Do what you need to do.
Yeah,
And,
yeah.
and so that's part of just, the practice of medicine. You have that spectrum of
Yes,
how people
yes.
respond.
That's right.
But what we have to do is make it so that the people that are most anxious are given the rationale and the information
Right.
to relieve their anxiety as best as we can as we get them through the process.
Yeah. Yeah, and I can tell you that I can reassure till I'm blue in the face and be 100% right, and they're not going to listen to me like they're going to listen to you. That's just the way it is.
So every diagnostic mammogram we do, we sit down and talk to every patient that comes in as a diagnostic mammogram, and we feel that's important because that's given the opportunity to explain what we're seeing and what needs to be done next without it having to be translated across 5 other people and say, what did they mean? But even then, when you know this, when you walk in the room and you say, there's something wrong, a lot of times the shades come down, the ears turn off, and you have to repeat yourself 4 or 5 times in the middle of that conversation, and if there's somebody with them, then get them to understand what you're
Right,
saying.
right.
Just because that fear. Now, and remember, what we didn't talk about earlier is that, across the country, we're beating breast cancer now, was it 94% on all cancers? So 9 out of 10 women are going to beat breast cancer from the onset of when we find it. No one wants to be that 1 in 10.
That's right.
But, when I say, hey, this is going to be a stage 0 or a stage 1 cancer, so, the odds are 99%, over 99% that you're going to beat this, my job at that point is to instill hope.
Right,
And
right,
I
right.
said, and I'll tell you this to women in this situation. Say, if I told you you had 99.5% chance of winning the $70 million lottery, you wouldn't go out and buy 20 tickets. You may buy 2.
Right, right.
And,
That's right.
and so if you look at it that way and say you got a stage 0 or a stage 1 cancer, you just got the lottery ticket because we're gonna, with the cancer center that we have, the team we have over at Nash, we are going to get them through the 5-year period, and we have I don't know if you know this, we put the bell on the wall, our 5-year cancer survivor bell.
I didn't know that.
So when someone comes to us for their 5th year and it's a negative mammogram and they're considered to be cancer-free, we give them a certificate and a breast cancer lapel pin, and they get to ring the bell. And then we have a tree of life that we put a picture up on the wall, so that, and I say to them, ring that bell loudly, because there's other women in this clinic right now that are on the road that you have just accomplished. And,
That's awesome that you do that. That's
yeah.
cool.
So and those days are the fun days.
Yeah, yeah. There's too many days that aren't fun
Right.
days. So you do 3D and ultrasounds all the time, sometimes?
We do.
What differentiates?
Okay, ultrasound is kind of like saying walking into a dark room with a flashlight. You can only see where the flashlight's pointing.
Gotcha.
So we use ultrasound. There's a push to do screening ultrasound there for a while, but the reliability of that for a screening tool was not proven to be efficient enough or effective enough. So it's good when you can sit down for 45 minutes and do a breast sonogram, but the practice of medicine doesn't allow for that.
Okay.
You know, so the screening mammogram is the starting tool for just annual. If a woman feels something abnormal and it's been there for 3 months, and you got that 4 data points, then you order the diagnostic mammogram, and that's where we'll do a mammogram and a targeted sonogram in that area. If we have an area of architectural distortion that we see on the mammogram, then we'll do a sonogram to see if we can see it, and we can a lot of the times, because an ultrasound guided biopsy, which would be the next step, is much easier to do and to ensure that we get what we're going for than doing a stereotactic biopsy, which is using mammography. And so that requires a woman to be in compression for an extended period of time, 15 minutes, while we target and go through all the steps that are required to ensure that we're getting at the right spot. And that leads to, when you asked me during break about, does it hurt?
Yeah. Some women say it hurts.
Some say it hurts, some say it doesn't. We have to do, the force of the compression is actually registered on the information of the mammogram. And that is something that is fed back into the FDA and the ACR, American College of Radiology, when we get certified, to ensure that we are compressing the breast enough. So we are required to compress the breast enough so that we can penetrate the X-ray can penetrate through the breast so that we're not missing cancers.
Right.
Now, that being said, the machine will compress to a certain level and then stop. And so the technologist isn't intentionally trying to harm the patient.
Of course not.
It's the machine and it's the program technology that says it needs to get to this compression so that we can get this type of image quality so that we can then be more accurate. And that leads back to that callback rate we talked about earlier. If it's incompletely compressed and then it looks like a mass and we have a callback, now we're chasing our tail and causing more anxiety. So what we also do is we have pink pads that we use on our mammogram plates to kind of little styrofoam kind of a pink pad to help give a little bit of softening to make it as best as possible. Plus the skin doesn't stick to the metal plastic plates. And so we do our best to take away the discomfort. But it's not a fun exam, and I have no other thing to say to that. But I feel for women having to go through it.
I know. So what about fibrocystic disease? Does that tend to have more cancers in it, or it's just something that happens to certain breasts?
It's something that, again, you can go look at some literature and it'll say there's increased risk of breast cancer for fibrocystic disease, and then you go see other literature that says not. And I think from my experience, it leads to a lot more imaging. And can I say point that this causes fibrocystic disease causes more breast cancer? No, I can't say that. I can say that it causes a lot of pain. Causes a lot of cysts. What it can do when it's really bad, and if women have a lot of cysts and they get to be 3, 4, 5, 6 centimeters, they obscure the tissue behind the cyst, and so we can miss cancers because of it. Or someone can say, oh, it's just a cyst. I have cysts all the time. It hurts to get a mammogram, and the woman doesn't go for 3 or 4 years and feel something, thinks it's another cyst, and it's actually a mass.
Right.
So it can lead to some diagnostic delays and dilemmas. But it's so common that we see it all. I mean, I actually will show women on the ultrasound screen when I come in the room and they're feeling something, and I'll show them what the fibrocystic tissue looks like compared to normal fibroglandular tissue. And it becomes more edematous, and as the hormones change, that becomes the edema, the fluid builds up, and that causes that pain, because like when you have to go to the bathroom and your bladder's distended, it hurts.
Right.
So when your breasts are distended, they're gonna hurt.
Okay. Well, it's time for our second break. I'm going to be on time this time. And when we come back, we'll talk to Dr. Singleton about more. I want to head out towards a little bit of men breast cancer because there is such a thing. So we'll talk about that and other things as well when we come back. Don't go away. We'll be right back.
At Downey's Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently. So we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Downey's Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Downey's Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
Hi, I'm Richard Goss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, hello, welcome back. This is Here's Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center. We're here with Dr. Singleton tonight. He's a radiologist that reads mammograms at the Nash Breast Care Center, which has all the top imaging equipment, and I'm so proud to be able to say that, and so proud to be able to send my patients to such a great place. Nash has worked really hard to keep up that certification they have, and they do a great job over there. So we're going to talk now about men breast cancer. Do men get breast cancer?
Yes, they do, but it's very, very rare. I can say this since I started medicine in 1999 and started radiology residency in 2002. I have never once diagnosed a male breast cancer. I have done more than a few screening mammograms on men that have developed gynecomastia, but none of them had breast cancer. I have seen, when I was in Bethesda Naval Hospital at NIH was across the street. And when I was in Mayo Clinic down in Florida, I saw follow-up patients that had breast cancer, men that had breast cancer. But personally, I have never, and I was just telling somebody this last week, I have never diagnosed a man with breast cancer. Not something I want to do.
No, of course
but about once or twice a month, we'll have a man come in who has developed gynecomastia secondary to medications or drug use or just gaining weight, and they'll get a mammogram, and 99.9% of the time the mammogram is negative. The main thing is for men is to do a breast exam, especially if they have gynecomastia, is just a quarterly, monthly to quarterly, but routinely do a check to make sure they don't feel anything. We don't, even when a man has gynecomastia, we do not recommend screening mammography for him. So the report, the standard nomenclature is no follow-up, BI-RADS 2, the BI-RADS categorization, BI-RADS 2, no mammography required for a male. And so benign, but no annual follow-up.
So are they at a high, probably not, because you've never seen any, but do you think they're at a higher risk, like if mom had cancer,
well,
or his sister had cancer?
Possibly, and that would be something that, the genetic counseling, and then important to do the routine self-breast exam. But the reason why is men don't have the hormone cycle changes that women go through from, from puberty until menopause. And that constant, whether it be 26 days or 35 days, or that turnover of hormones, has the breast will proliferate, they'll get ready as the hormones change, and they'll swell, and then they come back down. Well, during that just means tissue is growing, and then cells are normally dying, and that turnover over 40, 50 years could be for some women, then hope is not 50, but 40 years could lead to increased risk of the cells turnover. And so that's how I think of it, is why men don't have the risk that women do when it comes to breast cancer. But men have prostate, and one in nine men get prostate cancer. So they should be more worried about prostate cancer than breast cancer.
So is I was sorry to tell you about my friend. Her mom died when she was 20. Her mother had 6 children, and the baby of the family died at 51, maybe 52, with breast cancer. Estrogen feeding, I think it was, BRCA2.
Estrogen positive? Receptor positive?
I think so. And now one of the boys, there was 4 girls and 2 boys, and one of the boys has prostate cancer. So is prostate related to breast?
Yes, they are. It's glandular tissue that's very similar on the microscopic level. And of course, I went to a CME course I went to a couple years ago. It was on breast imaging, and the presenter was showing similar slides from pathology of prostate and breast, and so there is a similarity. Unfortunately, prostate cancer is not as aggressive as breast cancer typically, and so that's unfortunate, because breast cancer comes on younger for women and then at an older state for men.
Yeah. Sad. All right, so can I just walk into the imaging center? Do you know this? Do you know anything about billing and that kind of stuff?
For screening mammography, you don't need a referral to do screening mammography, but you need to call and make an appointment. And we do have a program. They're going to, just like for me, for you, if I'm going to go get a lab, anything done, they want my insurance card, or they want, and so if someone doesn't have insurance, we have programs that we can get them into, or through the health department. So if they're through the health department, then they need to call the health department and then get a screening scheduled. If they have insurance, or they're self-pay, and there are some people out there that are self-insured. I had an Amish couple of years ago that, hey, we're self-pay, and I said, okay. They came in and no insurance, and they're very, very nice, and called the office manager and told him their name, and said, they asked if they could just pay it off over time, or whatever. We did a biopsy, and I can't. And I said, Don, just work with them.
Yeah.
You know,
That's great.
You know, do what
Yeah.
you know, do what we can legally can, and work with them, and because they said they're community self-insured, and they're gonna have to go to their neighbors to,
Yeah.
you know, and but we have the BSEP program, we have the health department, and but to get to, if you have insurance and you just can call the Nash Breast Care Center. I hope you have the number because I didn't bring it with me. Is it on the sheet that the newspaper?
Maybe it's on this one.
We're doing a great PR here for this.
Yeah, really.
And so.
Oh, 962-6100.
962-6100. And, you know, the substitute will take name and information, and from there, you get an appointment. But you don't need a referral for a screening mammogram. Now, if you have a palpable abnormality, then you would need a referral for a diagnostic. But just for a regular routine screening mammogram, for an annual mammogram, you do not need a referral from you tell us who the referring clinician is, and then if they don't have a clinician, then you are a surrogate for us.
Yeah, I can't remember my title, that's bad.
And so then we put it underneath your name, and then we get all the contact information, because going back to the FDA and MQSA, we're required by law that if there's an abnormal mammogram, that we have a callback, or we have a cancer. We are required by law to make every effort to reach out to that patient and not let them fall through the cracks. So the updated patient information is vital, because we see it. As much as we try, we still see patients fall through the cracks. It's supposed to be back in 6 months, and they come back 18 months later, and then that makes it, you know, very, very disheartening if the disease progresses.
Yes. Well, so I go and I have a mammogram, and something is found, and you do a biopsy, and...
Well, let's do it in the order.
Okay.
All right, so you call, you get screening mammogram. And we say, we can see you next week. Okay. Thursday, like we talked about earlier, with Thursdays, we're open after 5 p.m. for people for working hours, so we have extended hours on Thursday. So you come in at 5:30 on Thursday. We have a screening mammogram. We read our screening mammograms within 48 hours, 2 business days. Typically the next day we'll have them done, and we'll do between 50 and 80 screening mammograms in a day. And so we see something of callback. Our callback rate is right around under 8%. So 1 in 12 will get a callback. And remember, they want it to be between 6 and 14, and we're sitting right there between 7 and 8. And so we call that patient back, whether it be for abnormal calcs or potential mass, and a mass can be a cyst. By definition, mass is a solid or cystic, but it's new, so we need to make certain. Or it could be abnormal calcs, or it could be architectural distortion. And architectural distortion basically means that the breast parenchyma isn't flowing the way it's supposed to. So a good analogy is if you could take, you make your bed in the morning, or you take it out of the dryer and you make your bed, and you look and you see that there's a abnormal area on the bed sheet, and you reach underneath and it's the dryer sheet from Static Cling, you take it out and it lays flat. But if it doesn't, and it turns out to be a little piece of gum that's stuck together in the sheet, or peanut butter from your kids' sheets, then you know that it was real. So architectural distortion kind of pulls the breast tissue together, but it's not necessarily, when it's early, it's not a mass. It's just causing distortion, bubble gum in the hair. It's causing distortion. So we'll call those back, and then depending on if it's a mass, sometimes we'll go straight to ultrasound. You'll see that. Just recommend targeted right breast sonogram. But if it's abnormal calcifications or distortion, possible distortion, then we'll start off with a diagnostic unilateral mammogram. Right breast if it's the right breast, left breast if it's the left, and then go on, if we need to an ultrasound. So that's the diagnostic. So we try to get those scheduled within 3 to 5 days, but depends. That was before COVID, BC, as you said. So we try to get those diagnostic mammograms in, but because through COVID, with everyone having decreased working hours, throughout the area. We opened up sooner, our breast cancer center. We have been, let's just say, even though our total numbers are down for the year, our diagnostics were booked because we're getting a lot of referrals. And so we're not meeting my goal, which is have a diagnostic within 5 days of the screening exam being read. We don't always meet it, but we typically do. Right now it's tough because of COVID. And so if we see something on that's abnormal, and from the diagnostic, and we would say, we recommend proceeding to biopsy. We would do that if the callback rate's 8%, and we bring back, so that's 8 out of 100 we call back. Out of those 8, maybe we'll biopsy 1 or 2 of those. Maybe 3, but if you start biopsying more than 25% of your callbacks, then your biopsy rate looks to be too high, which means in that annual review, they come back to say you're biopsying too much. And unnecessary procedures. So all those numbers kind of fall into place, and then we do the biopsy. If you're so you've fallen into that category where we did the biopsy. Of those, about 15 to 25% will come back as actual cancer. But those are how the numbers.
Still pretty low percentage.
Yeah. I mean, we did 8,000 screening mammograms, and we diagnosed just under 200 that weren't referred to us, but were we diagnosed from our screening mammograms. We diagnosed just under 200 primary breast cancers. Wow. From screening mammography. So, but there's a study that was a couple of years ago. I mentioned when I was on the show 3 years ago. 1 in 6 black women and 1 in 3 white women reported that they had a mammogram in the year of 2017. So that means 5 out of 6 black women and 2 out of 3 white women over the age of 40, didn't have a mammogram. So a lot of the cancers we are diagnosing or we're capturing are the diagnostic mammogram, where someone's coming in with a mass that they haven't had a mammogram 3 to 4 or 5 years. And that's the problem that we face, and especially with COVID going on now, is getting women to actually come in and get a screening mammogram. Because an ounce of prevention is worth a pound of life in this, and so we can't change the numbers. The numbers of breast cancer prevalence is, as you asked me earlier, staying for my 20-year career. Yeah. But we can't change that. Right. But what we haven't changed or been able to make good headway in is actually getting women to do their annual screening mammograms. Yeah. And so I ask everyone, please get your annual screening mammogram. Do it. All right. It's time to go. This has been the fastest hour of the day. Wow. I really appreciate you coming. You're very welcome. Wealth of information. Y'all, do your screening do your breast exams, get your mammogram. If your doctor isn't doing it or you don't see your doctor on a regular basis, call the Breast Care Center, 962-6100, and they will set you up and you can have it all done. And as Dr. Singleton said, an ounce of prevention is worth a pound of cure, or a pound of life. And we want you all to be around forever. So anyway, thank you so much, and we will see you next week with more of Here's to Your Good Health. Good night. Good night. Thanks so much. I really appreciate it. Awesome.